I'll start with Professor Shafi Ahmed. He is an award-winning cancer surgeon at the Royal London Hospital. And he's going to talk about, does MD stand for more data? So let me introduce Professor Shafi Ahmed first. As I mentioned, he's a multi-award-winning cancer surgeon, works at the Royal London Hospital. He is a member of the NHS Assembly, advising the government on the NHS long-term plan. He was awarded the Future NHS Award by members of Parliament in 2018. He was also the Asian Star in the UK Tech in 2018. He's won the Silver Scalpel as the Best National Trainer in Surgery in 2015 and has been given the accolades of World's Most Watched Surgeon as he streamed live operations using Google Glass, virtual reality, social media, and on national television on Operation Live. He is a 3-time TEDx and international speaker, having delivered over 250 keynotes in over 30 countries. He will be joined here on stage with Mr. John Nosta. He's the founder of Nosta Lab, a digital health think tank recognized globally for an inspired vision of transformation. He's currently ranked as one of the leading global influencers in medical innovation and technology, and well established as one of the top global strategic and creative thinkers. He's also one of the most popular speakers around the globe, presenting his vibrant and insightful perspective on the future of innovation. His focus is on guiding companies, NGOs, and governments through the dynamics of exponential change and the diffusion of innovation into complex systems. He's also a member of the Google Health Advisory Board. All right, we are going to go ahead and bring them both up on stage. Professor Shafi Ahmed, John Nosta, welcome to
here we are.
The DATAcated Conference. Hello, there you are. I'm going to stop wasting time. I'm going to hop off the stage here, and I'll be back in about 15, 20 minutes.
Okay, okay.
Thanks for the t-shirt, Kate. Hope we did you proud.
Awesome. Thank you. Thank you, John. Thank you.
Well, first of all, Shafi, it's always unfair to be on stage with you because your credentials are so good. I think I'm gonna have to lie more on mine. So here's my thought is that I think I'm gonna stick with the D word, and everything I'm gonna talk about today has to begin with the letter D. And I want to start with this, of course, going to the notion of data, but well, as I look at clinical medicine, what's going on, there are other precursors to this. And I want to discuss that with you a little bit, because I think that ultimately what we're seeing is the digitization. So we kind of start there, that we're digitizing so many things in clinical medicine, from digitizing an arterial pulse tracing in the operating room, to digitizing heart sounds, to carrying it down that line. And that takes us to the other Ds that I want to kind of put in perspective for our audience, not making this super technical, but digitization leads to demonetization. So now I don't need all that big, heavy equipment. I can do it virtually or anywhere. And the demonetization leads to the dematerialization. And that dynamic, I think, is what you're doing. So the final D in this construct is that what that gives us is the unique opportunity to actually democratize healthcare. So I want to talk about that a little bit. In your experience as a clinician, relying on human touch and relying on so many fundamental things, how is digitization and demonetization and all that stuff really making an impact in the operating room? Because that's where I see a lot of it happening.
Yeah, John, I think let's put it into context. We'll talk about my own special surgery in a moment and how we're changing the face of surgery using data. I think where we're living at the moment, with the pandemic coming through this entire year, we're seeing data being used in much more broader sense. That means access to patient records, electronic health records. We're seeing more data being shared. That obviously has conversation around confidentiality and data sharing agreements, etc. And that's another conversation for another day, I guess. It's all about the kind of the remoteness of patients. We've seen telemedicine coming in, doing remote consultations taken off by 8,000% or so the last few months. That also helps us manage those patients with chronic disease better. For example, in the NHS in the UK, 60% of all the resources are actually used to manage patients with chronic disease. And it's been inefficient use of time and resource. Now we're seeing diabetics, COPD patients, asthma patients being managed in the community. And now we're seeing the data being shared, for example. John, we have access to a lot of data, biological data. We both got the iWatch 6, which measures your oxygen levels and your ECG, giving valuable data in real time. I've got this new blood pressure a little machine now, gadget, continuous blood pressure monitored 24 hours a day. So now we're seeing more and more data being acquired in real time. We have garments now that be able to embed some of these parameters. And so, we talk about the wearables, the injectables, the ingestibles, electronic health records, massive data, and genomic data, of course, became more affordable. I just want to show you one thing very quickly, Joe, if I may.
Yeah.
I was given this today. This is, which you can see this. This is the pill cam. I've just opened for the first time. So this is a camera. You've got a camera. You get this flashing away, which you can swallow, which takes images, real-time images, and you can use data analytics to reconstitute the colon, the bowel, for example, to look at lesions. Now, we're just launching this for bowel cancer screening, rather than having colonoscopies, for example. So as this gives you more and more data, you have to screen going forward. Imagine connecting this with 5G technology, real-time monitoring of people in real time across the world. So that's the value of data being not just on its own, but with other technologies that we call exponential, John.
So interesting. I just read today that the guidelines are being changed in the United States for earlier detection of colon and rectal cancer down to age 40 for first screening.
Great.
So that's great, but we know that everybody is non-compliant with colonoscopies.
Yes.
But by swallowing this pill is really interesting. So again, the premise to my discussion here is that you still have to digitize the darn thing.
Yes.
Right? You need that camera, and you're making, look at the sigmoidoscope, or the scope that's used now. It's a big thing. This is something you literally swallow. So I think that's really interesting. But Shafi, here's my concern, and it goes back to data. Is data a four-letter word in clinical medicine today? Is there just too much darn data? Do I have to bring my genomic information to the doctor? And when I do, he or she's going to get angry at me. Like, how do you put that in perspective?
So the system's not ready to understand what that all means, John. It's work in progress. What we do now is understanding what personalization means, what precise medicine means. We've got these terms that have been used for the last few years, is becoming much more mature in our understanding. I think these small steps. Obviously, if you look at the entire health ecosystem, we need to understand what it means, analyze it. Also, it would be about patient empowerment, John, having data at your fingertips. So, for example, just over the last few days, NHS app on my phone now has my vaccine data entered in all my data. So I can now use that as my vaccine passport. So dragging valuable data that's relevant going forward and having practical solutions to society at large. So we are seeing real-time applications of some of these, but with all of this data, it's going to be time taken. And what we need is good data scientists, good data analysts working together in collaboration with engineers, with software engineers, with computer analysts to figure out what that can look like in the future. So I think it's really promising. And I'm really excited by what we can do with that as we go forward. And just last thing about surgery, you mentioned earlier, John, my own specialty has been transformed. The OR has been archaic in the way we perform surgery, with crude outcomes of 30-day mortality rates or morbidity. Now we're seeing computer vision. We're seeing real-time analytics during the operation for laparoscopic surgery, for example. So you can see structures using computer vision and data analysis. Also, the outcomes can be measured more accurately. So soon we'll be able to really be much more precise in determining the outcomes of the operation and looking at the performances of a team and individual surgeons, which is much more valuable, John, than before.
I'm gonna finagle my way to the patient a little bit, but before we get there, I'm gonna have my show and tell too, which I think is an example of what is really going on. That not only we have PillCam, and again, dematerialization, making it small, but we have this little gizmo that I can hold in my hands, and that takes my EKG. And another similar device is what we probably never guessed, that this is a stethoscope. And I put it on my chest, and the stethoscope tracks heart sounds, and it also tracks the EKG and superimposes both of them. And what that does, it creates something called a systolic time interval, and it allows you to measure something as specific as cardiac contractility. In other words, how well your heart is squeezing. The point I'm making here is that we've gone from this EKG machine and this stethoscope, which, the use of the stethoscope, Shafi would know this. The role of the stethoscope is to identify the doctor in the room, right? Because it's hung over their neck. But now it's this freaky thing. But look where it lives now. It doesn't live in the domain of the cardiologist or in the domain of just the physician. It's the patient who buys this on Amazon today. And it's the patient who very well may use this device to measure heart failure while he or she is at home. So Shafi, I want to talk about, the emergence of data and all this stuff, but how do the patients fit into that? Is the patient the arbiter of the data now? Is the patient the collector of the data? And how important is their role in this new clinical dynamic?
That was a great question, and you're absolutely right. We often don't put patients at the center of medicine, and we've struggled with that for many years.
Mm-hmm.
I think with the future, with data and these technologies, I think there'd be a tendency to involve the patient more, because they have to.
Mm-hmm.
Because it's about understanding what data you can collect safely, getting their consent to that process, ensure they understand what it means, and having it at their fingertips. If we're moving away from sick care to well care, maintaining well-being, John, in the community, then that only means the patient has more empowered with their own data sets to ensure they're complying or adhering to medicines or their therapies, for example. So I do see a move away from the hierarchical method of medicine, where we know best and this is what you have to do, to much more collaborative effort with the patient and a kind of a joint conversation. I am seeing that happen much more regularly, John, which I think is a good thing. A patient needs to be in control of their own destiny and their medical therapists.
That's interesting. You mentioned telemedicine, and during COVID, telemedicine peaked. It went up. But what I'm seeing is telemedicine actually going down now. In some scenarios, it's almost returning to February, March baseline. And I'm curious, I have my theories about that. What's going on, Shafi? Do you think who's driving telemedicine? The patient, the doctor? Who is the obstacle? What are some of the things? I'll let you go first, then I'll kind of throw out some of my insights around this, because I think it's important.
Yeah, sure. I remember you sharing that bit of data on social media around the fact that it went up really quickly initially, and then it came down rapidly. So the first thing was, when we came into the pandemic, we were forced to do telemedicine. It wasn't a choice. We had to do it. Therefore, utilization went up much more than expected. Then as you go back to face-to-face, as you open up, obviously you want to do more face-to-face. It's our comfort zone. You get a better, I guess, for certain patients, it's much better. And so some people would revert back to normal, back to type, right? The not new normal, but the old normal, John, that we're trying to get rid of. So that was going to be inevitable at some decline. The question is how to make it stick to a certain level to ensure that we judge it correctly. The patients who need telemedicine get it because it's at their convenience, more appropriate. Others who don't need to be seen and can be seen directly, it's okay. So I think now it's about the balance, getting it right. And I think it will swing one way and then back again. I would find a happy medium over a medium to long term, John.
One of my observations is that, as much as I like to talk about this crazy gizmo to take your EKG, and the fact that you can buy it for $89 US on Amazon, this is not an access problem. This is readily available to many patients. It's still not seen as a tool to be used during telemedicine in many instances. And my point is, if you go back 5-10 years ago when we were, messing around with the web, maybe 20 years ago, the early web was not a very friendly place to be. It was hard to navigate. It didn't have a very good user experience. Then what happened is that we found that we can actually create something that is dynamic, and that user experience, the UX, emerge as a powerful tool to not only drive functionality, but engagement. So I'm on this website and I like it. I'm tooling around. I think that telemedicine today is a meager transfer. We've basically taken the office visit and pushed it to a Zoom call. And there's not much technological sophistication. We need to create a clinical experience that allows us to leverage technology, like maybe a stethoscope, maybe an otoscope. Maybe there are certain things that we can use. So for me, I think that we need to move to telemedicine 2.0 or 3.0, and I don't think that's going to be an easy path forward.
No, and I think you picked up a few points there. Okay, you can see somebody face to face. What about the basic observations you do routinely as a checkup as they come to the hospital? I think that is going to be a key part of it. And the other thing that we struggle with always for the data scientists out there is interoperability. It's the one thing that comes up again and again and again.
Yeah.
Old legacy system trying to connect with new systems, we're using electronic health records like CERN and Epic, and trying to force things to merge together. So we've struggled with interoperability.
So let me stop you there, Shafi, because I want you to explain that to the group a little bit, because a lot of the people listening to us are not physicians, they're not clinicians. So what does interoperability mean? You know, if I'm a patient or a clinician, take a step back on that.
I guess that if you look at the basic tenet, it's the electronic health record for patients. And the question is, if you add some data, say you want to use your machine that you've got there, for example, the measures your ECG, and you want to connect that into electronic health record. How does that connect? What's the API look like? How do you make it easy so that people can look at it immediately, enjoy it? Or a blood pressure cuff, for example, or another system for pathology to get results in, for example, or the PAS system for X-rays. How do you connect all those together to make it easy for someone to navigate? And that's what interoperability means. And obviously what we've done is we kept building on systems, building, but actually it's finding it hard for legacy systems to connect to future kind of pathways. And I thought always sometimes the EHR isn't fit for purpose. We change it all, get a new one in so it connects properly for the future. And that would take a bold person.
That's great.
With those systems.
Shafi, I want to just jump on one other topic, and I know Kate is back up on with us. Is our human ability to inculcate, to assimilate data and knowledge into our lives, whether we're students or whether we're physicians, is that ever going to be able to keep up with technology? I mean, it seems to me technology is advancing faster than our human ability to absorb it. So that's a lose situation to me. I mean, what are your insights?
We can turn it on its head, John. Of course, we can't have all the knowledge in the world. We've got Google search, that's much more powerful. We've got to be more smarter. I'll bring this information in to your handheld to summarize things. Even public papers and research papers, for example, can be used now using data scientists to bring in the correct data for you and the correct answers and conclusions. So I think it's an advantage to have this amazing data and these clever data scientists to bring it to us, for example.
I think that, and just my final point in closing here is that I think there's a psychological component to this, because when we speak to physicians, they are often identified as the smartest person in the room. It's just the hierarchy of medicine. The doctor is smart. And one point is that as we have collaborative care, I think that not only is it the doctor working with the patient, working with the technician, working with the family, but that collaborative care must include technology. It must include the computer. And I think it's going to flip doctors out when they begin to understand that the smartest person in the room isn't the person, but is the technology.
I'm sure you're right, John.
Okay, guys, thank you so much. And I apologize for interrupting. I just want to make sure we do take a couple of questions from the live audience.
Sure.
The chat has been exploding with just the level of speakers that we're having on our show today. And thank you so much for giving that talk. I'll start off with a question from Alyssa here. She's asking, in 5 years, how do you see the use of data will change the way healthcare is delivered?
Shafi, I'll let you go first, because you're a real doctor. I only pretend that I'm one.
So no, I think it'll be obviously more important. I think data will be the heart of patient engagement. I think they will be using, we talked about this personalized approach to medicine or precision medicine, so that each individual gets to use their own data to understand the therapies or treatment that might be required, for example. So we're bringing individualized medicine into practice. We're already seeing it now. In 5 years' time, it'll be much more mature. We can actually get treatment that you require. And I think the other thing I said before is about sharing data. Patients will access their own data from remote places on their smartphone and the computer, and we'll see much better engagement with that data sharing agreements that we need to have with our patients.
I agree. I think that personalized care, customized care is definitely a point in the continuum, but I want to extend that curve out farther, because it is my desire that personalized care become obsolete, that we don't need it. And this is my premise, is that I think that early detection and an appropriate analysis of data, blood glucose, weight, the back of your eye, all sorts of kooky things will actually get us to a point where we can get to stage 0, where we can get to an earlier and earlier path. Now, my mom and my grandmom always told me, eat your vegetables because it'll keep you healthy. I believe that the path to prevention is actually a technology-based path where early detection and disease detection allows us to get to a place where personalized therapy is going to be trumped because we can eliminate disease before it becomes clinically or systemically relevant.
John, when you said you want to move away from personal care, at first I was like, wait, what? And then now I get it. Yes, prevention.
Yeah, I don't want the disease in the first place, Kate.
Yes.
I don't want to customize therapy for my heart attack. My God,
Absolutely.
That's barbaric. I want to prevent it from ever happening.
Yes, great point. And I also really love the kind of show and tell that you guys have brought to the conference. We do have several questions on some of the gadgets that you were sharing. So there's a question here from Bharat. This is for Professor Shafi. He's saying the pill cam is mind-blowing as a less invasive diagnostic method. However, how much is it reliable compared to an actual colonoscopy with respect to the quality of digitization and data?
Yeah, really good question. Thanks for that. Look, I think if you look at what we're doing at the moment for colonoscopy, we're seeing new technology using AI. For example, Medtronic have got the GI Genius. So as you do the colonoscopy, it sits with you on a little monitor and it analyzes to look for polyps and small lesions. And it's doing very well, and that will get better and better as more data sources are acquired over the course of years. So we're really using AI. Now imagine using that same technology now into a pill cam. So as you swallow the pill cam, use that same knowledge from the colonoscopy and like GI Genius or something, and looking at data through the colon, analyzing it. So actually, it could be just as good. I think that, of course, the other thing about having these small cameras and things, it takes a risk of perforation, damage, pain, anesthesia, sedation, inpatient stay, all expenses and risk to the patient. So the balance is, you might miss a few small lesions. It's absolutely entirely possible. But the balance of risk versus benefit is going to be in the favor of a pill cam. So I think that's the judgment.
I think you hit the nail on the head there. And it goes back to data. It comes back to data. And the example I'm going to use has nothing to do with medicine. Let's talk about Tesla. I mean, because the magic of Tesla is the accumulated data that makes the car smarter and smarter and smarter. That's really the market advantage. That's why Google bought Fitbit, not because of the technology. They bought it because of the data. And as PillCam gets used and used and used, we're going to be able to optimize those algorithms. So to me, I mean, that's a really, really interesting dynamic. Now, here's the other side of that coin. We don't have to make everything equally accurate. You know, when we make a stethoscope, it's going to be different than the stethoscope the cardiology uses. And these different levels will suit an appropriate need. So maybe I will get a pill colonoscopy every 5 years from the time of 20 because it's inexpensive and easy. That modality has to be looked at completely differently than that one Uber colonoscopy at age 50 where I need to find that darn polyp, you know. And the downside to PillCam is that you have no intervention, that if I see a polyp, I can't remove it. But it creates a new clinical dynamic. It changes the game fundamentally. And I think that's why it's so exciting.
Absolutely. And we have probably 100 or 200 questions that are just flying at you guys. And unfortunately, we are
Nosta at John Nosta on Twitter. And Shafi, you are at Shafi.
Ahmed 5 or LinkedIn, whatever. I'm happy to answer the question.
Or LinkedIn. We're live streaming on LinkedIn, so you can find Professor Shafi Ahmed and John Nosta on LinkedIn. They love questions, clearly, so go ahead and send them direct messages. Whether or not they'll have time, I'm not sure to respond. But guys, thank you so much for joining us here today. Really, really great discussion. Thank you.
My pleasure.
Thank you so much, Kate.